Okay, now I think you can start one more time. Okay,
Okay.
so your time
Uh,
starts now. Please.
okay. I wash my hands. Hello, I am Rohini, one of the doctors in the hospital. Is it okay I can go ahead and examine Ramesh today?
Yes, yes, please.
Thank you. Hello, Ramesh. How are you?
Yeah, Ramesh is fine.
Okay. Is he able to talk? Who have you come with today, Ramesh?
Yeah, my mama is there.
Okay. All right. Okay. Is he in any sort of distress?
No,
Any dysmorphism?
no.
I can see he's a somehow thin built. How are his dimensions? His height is okay.
Yeah, not appropriate with the age. Okay,
Mm-hmm.
head circumference also
Yeah.
normal.
Okay. Okay. And I can see there are no devices attached. And the surroundings also seem to be normal. I can, however, see a tag on his hand. Seems like he's admitted in the hospital. Okay, Ramesh, just I can see there's a deformity in the right hand, upper hand. I can see the bones, mainly the proximal bones look fine. The distal ones appear short. I cannot see a thumb.
Okay.
Um, yeah, probably some radial as well as thumb deformities are seen on that side. However, the other side of the limb appears to be normal. Um, so now I'm asking him to hold his fingers together. Ramesh, are you able to keep your fingers together? Any clubbing that I can see?
No clubbing,
Any cyanosis?
no sinuses,
Pallor?
no pallor,
Any signs of infective endocarditis, Janeway lesions,
no,
osseous nodes,
no, no,
hemorrhages? Okay.
no,
Any cannulation markings on the hands?
no.
Okay. And I note that there are no, are there any puberty signs? Any axillary hair?
Well, very good. No.
Okay. So now I want to look at his face. I know that there is no dysmorphism. Am I seeing any jaundice or pallor in his eyes?
No, clinical pallor is there, but no, that is not significant. Otherwise, no jaundice.
Any abnormality in the eyes?
No.
Okay. In the mouth, is there any, and how is the oral hygiene?
Well, oral hygiene is good.
Okay. And any cyanosis, central cyanosis I can note?
Well, no sinuses.
Okay. I'll go down to the neck part. I just see it's slightly broad. However, are there any swellings or any visible pulsations in the neck?
No.
Okay. So now I will go ahead. I'll make him sit down and lie down on the couch, maybe to 45 degrees. And I'm now trying to look at all the sides from the sides and the foot end. Do I note any asymmetry in the chest?
Yeah, there is a bit asymmetry, as you
There
can
is a
see in
bit.
the. Yeah.
Yeah, it's a bit asymmetry. Is there a precordial bulge that I can see?
Yeah, slightly.
Yeah, yeah. Any apical impulse or any visible pulsations on the chest?
No.
Any scars on the chest?
No.
No. Okay. So now I want to place both my hands on the chest to find out where the apical impulse is. Is it in the left or the right side?
It's the left.
Okay. Where exactly is the apex?
How will you check?
So when I place both my hands, I'm going to feel the impulse, and then now I localize it properly with one finger. And now I'm trying to locate it with respect to the mid-clavicular line and the number of intercostal spaces. So which
Okay.
intercostal space is it?
Fifth, mid-cable line, fifth.
It is in the mid-clavicular line. Okay. After this, now I want to palpate if there are any thrills that are palpable. And I'm looking at the apical area, looking at the
No,
tricuspid,
no,
herbs area, second intercostal space.
no,
In the neck, any thrill in the neck, suprasternal area?
no.
Okay, I want to place my hand on the parasternal area to look for any parasternal heave.
Well, no,
No, no parasternal heave. Okay, I want to palpate the second intercostal space. Is there any palpable P2 that I can feel?
no.
Okay. So then now I will go ahead with the auscultation. I want to start with the apical area. What do I note? Is there any, can I hear S1 and S2 in the apical area?
Auscultation.
Yes.
Yes, yes. S1 and S2 is audible.
And how are the character of S1 and S2?
S2 is bit loud compared to S1.
Loud. Okay. And how is the splitting for the S2? Is it normally split or how do we?
Yeah, there is
Okay,
a
I will look at the splitting at the pulmonary area. Um,
okay. There
you
is
said
a
is
split.
it
Split is there.
okay? And does it vary with respiration?
No, that is fixed splitting, and there is a mark.
Okay. There's a murmur in the second left intercostal space.
Yes,
Okay. And
upper
is it
upper.
best heard there in the
Y-
second intercostal?
Yes.
Okay. And is there any radiation of this murmur?
Why will check radiation?
Either to the axilla or to the back? Is there any radiation?
Well, in the axilla there is no radiation, but it is not radiating to the back as well.
Okay. And what is the grade of the murmur?
It's near about three. Near about 3 out of 6.
Okay. 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 And apart from this murmur, are there any other murmurs in any other areas in the tricuspid, in the aortic
No,
bulbs area, or anywhere else?
no.
Okay. Okay. So now I would like to quickly examine his back.
Okay.
Do I
Wait.
know?
Time up. Time up. Wait. Now I am giving you some extra time to hear the murmur. Okay. If it is audible or not, let me know. Okay. So just a minute. Can you hear?
Yes, yes, I can hear.
Okay. Happy with the murmur?
Yes, yes, yes.
Okay, fine. Now continue, please. Your
So
6 minutes is up. Okay.
okay, so to complete my examination, I will examine the back, also auscultate the basis of the lungs. I will palpate for the liver, and also look for pedal edema. I would also maybe like to also examine the femoral area for this child, for any scar marks, if allowed.
Okay.
Um,
Present your case.
so So today I got an opportunity to examine 10-year-old, 10-year, 4-month-old Ramesh. So on my general physical examination, what is very striking is he has a limb deformity, most likely looks like a thumb in the radial anomaly. Apart from that, I have noted there is a precordial bulge that is present, and the apex is in the fifth intercostal space in the metaclavicular line. I note that there is the S1 and S2 is well heard. In fact, S2 is slightly loud, and it is also split, and it is fixed split. In the second intercostal space, I note an ejection systolic murmur, which is grade 3. It is not radiating to the back or to the axilla, and I do not note any other murmurs anywhere else. And So putting all together, I think considering the limb anomaly and the features of ejection systolic murmur, I would like to consider a diagnosis of ASD in this child.
Okay. Any other feature that is related with ASD in this child? Any other diagnosis? like not the
Any
murmur
other?
as a whole.
Sorry, Dr. Pranab.
Any particular syndrome associated with this?
Yeah, Holt Haram is associated with limb anomalies and ASD.
Okay,
Yeah.
okay, fine. So, what are the investigation you want to do in this child?
So first of all, I would like to plot the height, weight, and head circumference on a growth chart for this child. I would also look through if any other investigations were done in his file previously. And then I would like to examine his forelimb blood pressures and saturations for this child. And then in the investigations, I would like to do, first of all, a chest X-ray. On the chest X-ray, I'm mainly trying to look for any right ventricular hypertrophy cardiomegaly features, and also if there's any pulmonary plethora. Um, on the ECG, I'm again looking for right ventricular hypertrophy. ASD, most commonly,
Well, time up,
what is known.
time up. Thank you. So the thing is, I'm repeatedly telling 11 people are there, including me. So all those are already got the seat. This is my request that when you are going to present your case, you need to remember the timing, because in clinical station, if you are not reaching up to the part of management, there is nothing in the hand in the exam. I mean, on the there is nothing. They cannot do nothing. So
Hmm.
just try to restrict your presentation just with the positive findings, and give them a chance to ask few questions, because this time management is ultimately very very difficult in clinical. Okay. And apart from this, in this particular child, your examination technique was very good. There's no such concern. But what happened? Uh, Marks. If you see the domain, domain is consist of just like introduction, and after that, wipes. Everybody know that. And after that, any dysmorphism is there. And so that all included in the first part. In general observation, you have observed the growth parameters, including the like devices and all this. In general examination, what are the positive points you have got in this check? So here, as you can see, so this is with picture actually. That is sometimes difficult, but what happened? This radial shortening definitely there, but you need to palpate when you are checking the pulse, whether this is in within the area is there or not. Sometimes we need to check. And after that, if you see if you see the other hand carefully, there is also some abnormality in the finger. So that is not possible in like online examination to pick it up. But the most important finding here, the limb length discrepancy as a whole, because the distal part is short, right? Here, if you ask the child to raise both the hand together, you will find it out that one limb is larger than other. So that is the finding, and that you need to pick up and just add in your presentation. Okay. Along with this, bony abnormality and this limb length discrepancy. Apart from this, there was no such cross dysmorphism. But if you see left side, you rightly picked up, there is some bulging definitely there. Now they will ask few questions about the investigation management, including the DDs of murmur in this particular area. So what may be the DDs of murmur? Can anybody suggest what are the DDs in this particular area?
That may be pulmonary stenosis.
Yeah, right.
Uh, Other is sometimes outlet VSDs are also heard over that area.
Yeah,
And
but mention the common thing, because this examination is like Mrcpch clinical is mostly, if you are mentioning the common thing, they'll be happy. Okay, this can be mentioned, but at the last, some more common thing.
Pulmonary stenosis, then
Innocent murmur can be.
ASD,
Yes.
and innocent.
Innocent murmur, ASD, pulmonary stenosis. These are the three classical murmur that sometimes can be. And if this is a large as a small VSD, this VSD murmur, yeah, that is a pansystolic, but that can be heard over all these areas, all over the precordium. So that is not particularly DD, but if they are asking whatever, then you can mention. Otherwise, no need. These three is enough. And after that, if you think they are asking, then what I think Dr. Ashish mentioned, you can mention that one also. Okay. So these are the DDs. They need to know according to the site of murmurs. You need to mention your DD. Now, few real fact in the exam. What happens? Sometimes they are keeping some difficult cases. So in the last time in Mumbai exam, everybody stuck with the child. Actually, there was difficult to pick up what was the murmur, and that was the large PDA, just like all over the precordium, including this aortic area as well. So that was very difficult to pick up, and everybody was at that time confused. And during the diagnosis and presentation, they presented in various way, and some candidate failed as well. So what happens? They are expecting the diagnosis which is relevant according to the site and the character of murmur. Got my point? Am I clear so far?
Yes.
Yes.
This can happen in next exam as well. That's why I'm telling you guys. So you need what is just like expected or relevant according to the site of murmur. So forget about the diagnosis. So if you got, because Hall-Torrance syndrome, maybe sometimes ASD, sometimes they can have VSD as well, but rare. But most common is ASD, right? So it does not mean that Hall-Torrance always will have this ASD murmur. So in examination, do not fix your mind with the diagnosis. Always be open. Now, according to the site of the murmur, and according to the character of the murmur, you need to present your case. And even if you are wrong, but logically you are getting the murmur most prominent, that is here. Okay, so present your case just like this. I am getting a murmur over the second left intercostal space, upper intercostal space, and that is most likely ASD, but my other DDs are this. Because PS murmurs not always radiating to the back. Am I right? Yeah. PS murmur, we know, all of us know that PS murmur usually radiates to the back, but there are certain cases this classical radiation may not be there. So that's why they are asking, and for this reason you need to check the back. Back is must for every clinical station. Okay. Now this child, if you remember, Dr. Rohini, I said there was a loud S2, right? So if this is long term, and the case is not untreated, when left untreated, and they are maybe waiting for spontaneous closure, the child is already 10 years. So if this murmur persisting for a long time, there is chance that this child may develop Eisenmenger syndrome.
Hypertension, yeah.
Right? So sometimes, remember guys, sometimes they may ask about the mechanism of Eisenmenger syndrome. Okay? So this is easy, but I'm just telling you what are the favorite area in the exam actually. Okay? Now, as I said, please do not waste your time, because they are not responsible if you are wasting your own time. Try to present, because in mostly the clinical station, mainly, as I said earlier as well, they are not checking your knowledge in this exam. It has been checked in AKP and in the part 1. This is the exam. They are checking the technique as well as the basic knowledge, how the approach in a whole word, this is called approach. So that's why try to present your case as much as possible, quickly with the positive finding, even if the examiner giving clue that tell me the positive finding, some of the candidate, again they're maintaining the whole sentence to describe the finding. So that is again wasting of time, nothing else. So try to summarize your case as soon as possible with positive finding, and if important negative finding is there, then try to sum up with the important negative finding only. Okay, in this way you will get the more chance to discuss with the examiner in the management part. Got my point? Okay, so this was the CVS case, and I think Dr. Rohini, you mentioned the blood pressure at the last, I think, right?
Yes, yes, yes.
So blood pressure and your like saturation is
Saturation.
must. Saturation and JBP is must. You check that one. But if someone is forgetting, so that is sometimes maybe they will deduct the mark. And now in this particular case, you need to check the nails as well. Nails. Okay. So start with the just like this structure in CVS. That is you can follow like Mrcpch or any kind of book, but try to maintain the structure in a right way. Okay. And scar here in this particular child, there would be no scar, but sometimes Hortoram syndrome may be there with scar, midline sternum scar, or maybe some with drain as well. So this case may come. Okay, they are giving any kind of cases nowadays. There's no like recall is not helping nowadays, but you should cover the recall mostly. Okay, and
Doctor,
yeah, please.
yeah, Dr. Pranav, can one of the DDs maybe TAR syndrome also?
Yeah, possible, but TAR syndrome, cardiac lesion, I am unable to recollect right now. The TAR syndrome is one of the DD, but there will be thrombocytopenia as well as this radial or that bone deformity. But cardiac lesion, I forget actually. If you remember, just mention please.
The
Yes,
other
yes.
DT could be Fanconi's anemia also. They can have AST with thumb
Right.
deformities.
Dr. Pranab, is there any widening of the neck also? There is, I can see some widening of the neck.
That is.
So then Noonan syndrome also, if it is associated with loud P2.
Possible.
And
That
if
is.
there's radiation.
That is also possible, but Noonan syndrome will be having more typical facial feature with ptosis, and these features will be there.
That's right.
Yeah.
And in that case, it will be pulmonary stenosis. So loud P2 will not be there mostly.
Mostly, yes.
And there will not be splitting also not fixed.
Yeah.
Yes, right. So that's why if they are giving Noonan syndrome, that will be very typical faces. So we'll practice with the Noonan syndrome as well. So okay, the Noonan syndrome may come, definitely may come in the exam. Okay, and mostly try to cover, if the important tip is, if sometimes your exam is taking some time to complete, do not forget to mention, in order to continue my examination, I would like to check the basal capitations and the liver. Because what happens in real exam, in a time management, as I say, time management is very difficult in clinical examination. So try to keep maximum time for auscultation. Try to keep maximum time for auscultation, and if you are missing last part of examination, just like checking the liver or this blood pressure and saturation, including the basal capitation, just mention, in order to continue, I would like to do this. Okay, and that is containing marks actually according to their perform mark. Okay, So structure-wise, I think you covered most of the thing, including the pivotal sign. Very good. And if the child is, the elder would more than 10 years or 12 years, 13 years, do not forget the puberty. Puberty is very important in every clinical situation. Okay. Okay, guys. Any other feedback? If you want to add here, please kindly add.
No, you told most of the things. I think she's calm and composed. So
Yeah.
she is very, yeah, it's approach is very good actually.
Good. Right. So that is the thing. That is
Dr. Pranav,
yeah.
Dr. Pranav, I have a suggestion that it's better not to say about any murmur, just let the people listen that.
Yeah. No. I will train just like with playing several mama. That is a different strategy. I will just give you just like hear and listen and suggest one by one. Okay, that is different strategy. I have that. Okay. So the next point is they may keep some smaller age group. That is you need to be ready for that, because if you are getting a child, that's why I have selected two pictures. That in the second picture, as you can see, that is near about 9 or 1 year, not 1 year, I think less than 1 year actually. So 6 to 9 months of age. Okay. So what happens in this kind of children? Sometimes they can because ASD syndrome after growing up, say spontaneously usually closes. Okay. Not all the variety, but sometimes the most common, most commonly this ASD cases usually found in a smaller age group. So that's why be ready for that. Okay. Mute yourself, guys. Okay. So what happens in exam settings? Sometimes they can give this small age group, and what happens? I will give you another suggestion that if you get some child with small age group at that time, remember guys, you need to break your sequence. Okay, you need to break your sequence. First you need to auscultate, because if you are doing the general examination first, there is chance that child may cry and not cooperating at the time. So you need to know how to approach in a smaller age group, in CVS particularly, because if you are unable to hear anything, you may lose the station. So this is another trick. So kindly just go and observe the child and quickly auscultate. Quickly do your auscultation first to come to a conclusion of the murmur. Okay. After that, gradually you complete your general examination. That is the actually way, because that already mentioned in like Mrcpch leaflet. There is, if there is uncooperative child, it's always better not to irritate the child. Try to auscultate first, and then you can observe or examine the child as a whole. So that is another part, and that sometimes may be ASD, or mostly because ASD, what happens, they are mostly present in a smaller age group. That's why. Okay. So that may be other cases as well. So not only ASD. Do not think that in a small age always that will be ASD. So try to auscultate. My actually I wanted to say actually. So try to auscultate first, and after that sort out the case. Okay. Okay. So I think we can move for the next, if you are willing to go for the next. Okay. Let me see this one. Okay. So here is a 3-year-old girl. Name is Sana. Okay, Sana. So who is going to practice in this case? Sana. Kindly examine the CVS.
Can I do so?
Yes. Who is this? Dr. Fatima.
Fatima.
Yeah, yeah, please. So, okay. Okay. So, are you ready? Whenever you are ready, let me know. Okay.
So we can start.
Okay. So, your time starts now, please.
So I enter the room, I wash my hands and then introduce, hi Sana.
Hi, Sana is playing with this book, and
So I turn to the mother and tell, I'm Fatima, one of the pediatric doctors working in this hospital. Is it okay if I examine Sana today?
yes, yes, please.
Okay. So I look at Sana, I look at her hand. Is there any clubbing or pallor present?
A bit pallor is there, but no clubbing.
Okay. And looking at her face, I can see she has icterus, and is there pallor present
Yeah,
in
yeah.
the
Slight,
conjunctiva?
pallor is present, and bit icterus is also present. You are right.
Uh, and then I will ask the mother to remove the dress, the top,
Excellent. Yes.
and
He removed.
inspection. Is there any scar present over the chest wall?
Well, yeah, there is not in the chest wall, but below the abdomen. I mean, below the right costum, right sub hypochondrium, there is scar.
So next I would like to check for the pulse. Is it regular?
Subcostal region. Sorry.
Yeah, okay. So next I would like to check for the pulse. Is it regular? What is the rate?
Yeah, rate is regular, and it is 80 per minute.
It's felt in both the radial artery.
Yeah, both the radial is palpable.
And I would also like to measure her blood pressure,
Mhm.
which I can do in the end. Then her saturation also.
Okay, saturation is normal in the air.
So there are no, and then on coming to the inspection, are there any scars in her axilla or at the back?
Well, no scar, no other scar is there. Only in the abdomen, the hypochondrial, this scar is there in the right
And
side.
is the apical
Subcostal.
impulse visible?
No, no visual epicals. No.
And is there any, so I will go to the foot end and see if there's any precordial bulge which is present.
No.
And is there any, are there any visible pulsations over the chest wall?
No.
Okay, so next palpation, I would keep both my hands and see if the apical impulse is felt.
Apical
Which
impulse,
side is it felt?
left side in fifth, midclavicular line, fifth intercostal space.
Okay, and is it hyperdynamic or heaving? Is there any special character?
No, character is normal, no special character.
And I would also check if there are any thrills over the
No thrill.
no thrill. Okay. And next auscultation, I would like to see the apical area, tricuspid, pulmonary, and the aortic area.
Okay, so in the apex, there is no such positive thing. In the lower left sternal there is a murmur, and okay, I will just play the murmur, and at that time you will be able to understand.
And is there any lower left sternal? Is there any radiation to the axilla or?
Look at me. Look at me.
Is there any radiation of the murmur to the back?
Yeah, there is a radiation.
Okay. So, and would also like to examine the base of the lungs and check for any hepatomegaly, and also check for pedal edema to see if there's any signs of failure.
Yes, hepatomegaly is there. 4 centimeter below the 4 to 5 centimeter below the costal margin.
Okay.
Just be,
And
yes, and no pedal edema.
okay. And as I would like to complete the examination by plotting her height, weight, and head circumference, and also check for the pollen BP and saturation.
Okay.
Mm.
So saturation is normal, blood pressure is normal. Okay. So you have got 1 minute more. I'm just giving you the murmur. Try to hear. Happy?
Yeah. Yes, sir. So I just want to know if the murmur is heard over the pulmonary and aortic area as well, or
Yes, very important. I'm waiting for that. That is prominent in the left second intercostal space, and that is less prominent just below. I mean, the lower left intercostal space as
the
well.
maximum intensity is left.
Yes, maximum in the left up, left side upper second intercostal space. Okay, and that is also ready to the back. Okay, so your time is up now. Well done. Now present your case.
So today I had the opportunity to examine 3-year-old Sana, who appears well grown for her age, and she has obvious icterus and features of Alagille syndrome with significant right hypochondrial scar. And on cardiac examination, I could appreciate a murmur, probably an ejection systolic murmur, grade 3/6, in the left second intercostal space, which is also radiating to the back. And she has no features of cardiac failure or infective endocarditis at present. My likely diagnosis would be a pulmonary stenosis and also pulmonary stenosis and also ASD also, but I could not appreciate any splitting. So pulmonary stenosis would be the first differential diagnosis.
Okay. Wait. So if you're presenting, try to limit your sentences. Okay. So as you said, there is no signs of failure. Why the liver is immobilized? Liver is the feature of failure. So why you are not?
Sir, due to the Alagille syndrome, there can be hepatomegaly.
Okay.
Cirrhosis, yeah, they can be hepatomegaly due to allergy.
Okay. So why this hepatomegaly is there? Alagille syndrome, jaundice. Why?
Jaundice is because there is a paucity of bile ducts and there is
Biliary hepatitis.
fibrosis.
Yeah. So have you checked the oral cavity? Have you checked the eyes?
Oral cavity, I don't check that for.
In CVS, that is important. Okay, that's fine. And apart from this, what are the investigations you want to do in this child?
So I would like to take a detailed history and review the previous files for this child. And, at present, I would like to do a full blood count and liver function test, and also for the cardiac part, and chest X-ray, ECG, and echocardiogram. So,
what is the expected finding in X-ray, chest X-ray?
Sir, expected finding in
Chest X-ray.
chest X-ray, there can be pulmonary oligemia, the lung piece can be there. And prominence of pulmonary oligemia, I'm not sure.
Okay, that's correct. And any other finding in the cardiac solid?
And since this is allegedly, there can be defects in the vertebra also.
Okay, that's great. And what is the eye finding in LIG?
Eye finding, there'll be posterior embryotoxin can be.
Excellent, excellent. That is not visible in generally in the just direct examination. Okay, so how you will manage this child?
Sir, I would like to follow a multidisciplinary team approach. I would like to involve the cardiologist to grade the pulmonary stenosis. I would like to see the gradient, and for her jaundice and hepatomegaly, I would like to involve the cardiologist should be involved, and then for her other symptoms, I think we should get an opinion from the gastroenterologist to see if there's any cirrhosis or signs of any. If there are signs of any liver cell failure, then gastroenterologist can be involved. And
okay, fine. So in this child, have you examined the spleen?
no, sir, I didn't look for other organs.
Is there any chance to get enlarged this spleen?
Allegedly, the hemal. I don't know. There can be malformations because of the because biliary tract is involved, so there can be associated splenic malformations.
That is the trap. That is a trap actually. So you got into that. So never mention something which you don't know. Don't make your own finding. That is the part in this exam they are telling this made up finding. Never ever go into the trap. Got my point? You have examined the child very well. You have given the diagnosis, and you were very close to the management. Everything was fine. You were at last you are making the finding, and with irrelevant just trying to make up. So that is they are not expecting. If something you are making your own finding, sometimes you may get even 1 or 2 or maybe 0. Okay, so that is called made up sign. So they will write it in your feedback that the candidate that made their own finding. So never. So here the spleen may be enlarged because of portal hypertension, because we don't know the extent of liver damage, right? Alagiri syndrome, and I say there was operation has been done, which is just right hypochondria. Yes, that is your mostly what operation they used to do in this child in biliary atresia. Yes, exactly. So you know everything, and you were just messing up at the end. Okay, so don't do that. Whatever finding is there, try to correlate the finding and present to the examiner, and you will get maximum marks. And somehow, if you are trying to make some finding in the exam, then you are in big trouble. Trust me. Okay. So otherwise, you did really well. Liver is enlarged here, not maybe due to failure. Okay, failure signs may not be there, but this is due to the particularly liver disease itself. Okay, so this was a bit complicated case. So this kind of cases may or may not be, but what happens nowadays, they are giving several types of cases. Any kind of cases they can give. So this covering 2 clinical stations. Number 1, it may come in your abdominal exam, abdominal station. Okay, post Kasai procedure and jaundice. And this may, if this is Alagili syndrome and associated with pulmonary stenosis, they may come, this pulmonary stenosis in cardiac, they can give rise to this case. Okay, so that's why this case is important.
So why was liver enlarged? Like, what
And this is for the chronic liver disease, actually the biliary hepatitis, as you said, na?
Okay, okay.
Right? Even post-Kasai procedure, they the 1/3 is improving very well. 1/3 is this
Okay.
the failure of Kasai is there, and 1/3 is this chronic hepatitis will be there. So this is the reason for alignment of this liver here, basically, not due to the failure. Okay, because there was no pedal edema, no basal crepitations, no tachypnea, okay, no tachycardia, just like that. Okay.
So every series we have to like mention like we have to examine the oral cavity.
Yeah, in why important? Because any cardiac station, if you are checking the oral cavity, you need to find out whether any dental caries is there or not. Because if the child is not maintaining the oral hygiene, there is chance to develop endocarditis. So that's why this is important. Even in some cardiac station, just like Marfan syndrome, you can get some high arch palate. Am I right?
Yes, sir.
So our several finding may be there. You may get pallor, huh?
Yes. Okay, sir.
And this dental overcrowding, and several finding may be there within the oral cavity. Okay, so that's why. And the rest of the part, I think you did well, but unfortunately, at the end, you that's not a
You
problem.
actually asked if there was like, did you examine the spleen? So I said I didn't examine, but it can be associated.
Actually, this is a severe station. But if you are suspecting jaundice, so it's
Okay.
better to check the
Or
in
we
your
can
family.
just mention in the end. I would like to do at least.
No, you are not going to fail for that if you are missing the spleen, but they will deduct maybe 1 mark, because this is one of the important finding. When you are palpating the liver in a child with jaundice, it is expected that you will check. How much time that will take, right?
Okay.
That's what. Okay, guys. So I think any other feedback, if you want, just add on, please.
Sir, because of portal hypertension, can there be splenomegaly in this case?
Yeah, that's the thing I said, no?
Okay.
That is the reason the spleen was there.
And we should also mention about when we are telling about the murmur, like we should tell about the second heart sound also, sir.
Yeah, definitely. Heart sound, you must have to comment. Definitely. So I think there's a book of Secret to Pass. Secret to Pass book is there. I will share this book in a group. So there is a beautiful line written how to present the case. But be careful, that is not wasting your valuable time. So if you try to read or memorize all the lines and trying to present your case, that will take whole 3 minutes. So don't go just like that, but try to memorize and try to pick up the positive finding and present to the examiner. Okay, that is the idea. Okay, so I will share this book in the group, Secret to Pass, and kindly go through the pages at the end of CVS system. Actually, there's nicely written how to present. Okay. Okay. So you want to practice any more cases?
Yes, if possible, one will do.
Yes.
Okay. No, try this one, Dr. Amar.
May I try, sir?
Yeah.
Raja, sir. Okay.
So guys, before starting this session, I repeat one more time, be careful about the made up sign. You may get 0 even. So very, very careful. Don't mention something which is not there in clinical station. Okay. Okay, are you ready, Dr. Amar?
Yes.
Okay,
May I start?
so your time starts now, please.
Yes. I'm entering the room. I'm washing my hands and I'm going the examination sheet to the examiner. So first I will take permission from Raja and her parent.
Yes, yes, please.
Today I'm going to examine Raja. It involves looking at the chest and also listening to his heart. Is it okay?
Yes, yes, doctor, please.
Thank you. So first I would like to look for any devices if there are any devices around.
No device.
Is the child in any distress?
No.
I'm able to see few dysmorphic features like smooth philtrum and uh, yes, few iris appears to have spots, but although I'm not sure. And
So if you are not
yes.
sure why you are commenting, okay,
Yes.
continue.
Yes. So next, how are the dimensions, sir? Height, weight, and head circumference?
Yeah, not well grown according to the chat. I am age actually.
Oh, oh. So next, I would like to first see for his hands. I will ask him to stretch the hands and see if there is any koilonychia or leukonychia.
No, no such finding is there.
Oh, any sphincter hemorrhages are there?
No,
I will ask him to turn over the hand and see if there is any Janway lesions or Osler's nodes.
no, negative.
Oh, any Palmer erythema is there?
No,
Any signs of peripheral cyanosis is there?
no,
Okay. Next, I would like to, in a very friendly manner, I would like to check his for clubbing. I will ask him to turn his fingers
no
up
clubbing.
and okay. So next, I would like to look at the pulse. How is the rate, rhythm, volume, and character?
Yeah, around 75 per minute and normal rate and weak pulses basically is there.
Okay. I would like to check both the hands for any radio-radial delay.
No, both the side in the hand and the weak pulse.
Okay. And I would like to ask Raja, are you having any pain in the hand? Can I lift your hand up?
Yeah, there is
And
no pain.
okay. Then I would like to lift the hand and see for collapsing pulse.
Well, there is no collapsing pulse.
Okay. With the dorsum of the hand, I would like to check for any rise of temperature in both the hands.
Okay, no rise of temperature.
Okay. Next, I will like to go to the eyes and see and ask him to pull his eyebrows down. Any pallor is there?
Okay, slight clinical pallor is there, but it's okay.
Okay. So, I would ask him to look down and pull his eyebrows up, upper eyelids. Any jaundice is there?
No jaundice.
Okay. Next, I would like to inspect his oral cavity. Is there any evidence of dental caries or central cyanosis?
No, no, no good hygiene, no sinuses.
Oh, okay. So, any high arched palate is there?
Uh, a bit higher palate is there, yes.
Okay. So next, I would like to help him undress, and next, I would like to go to the end of the bed and inspect his chest from the foot end. How is the shape of the chest?
No asymmetry and
Uh,
normal shape.
oh, so are there any visible pulsations?
No,
Apical beat is. Oh, are there any scars? Hello.
no, no,
Oh, oh. Any precordial bulge is there?
no,
Okay. Next, I would like to come to the left side of the child, and also I would like to inspect the axilla and back for any scars.
no scar.
Oh, next, I would warm my hands, and I would inform Raja that I will be touching him. And next, I would like to look for any feel for the apex beat with my both palms on both sides.
Left side
Where
is six intercostal space lateral to the mid-clavicle.
okay, so sixth intercostal space. Sir.
Mm-hmm.
Sorry. Okay.
Six, yeah,
How is the character? Is it tapping or?
forceful,
Sir, sorry.
forceful.
Forceful. Okay. So I would like with my palm, I would like to all the four areas. I want to see if there are any thrills or palpable.
Yeah,
hard sounds.
in the right side in the second intercostal space.
Right side second reverse. Okay. Next, I would with the with the palm. I would like to see for any parasternal heave. Is there any parasternal heave?
No, no.
Okay. Yes, sir. That next I want to go for the auscultation. I would inform the child before that I'm going to auscultate him. I would like to see it in the mitral area. And I would like to time the first heart sound by palpating the carotids. So,
First sound is soft, and
so
soft is sometimes difficult, and the second heart sound again normal.
okay. No murmur is there. Right.
Apex there is no murmur.
Okay. So next coming to the tricuspid area, how about the first and second heart sounds any murmur?
Oh, it's a soft murmur that is not prominent here actually.
Okay. Next coming to the pulmonary area, left second intercostal space, any murmur or first and second heart sounds?
Yeah, the same murmur is there, but intensity is not maximum here as well.
Okay, sir. Next, coming to the right second in the aortic area. What I mean,
Yeah, your 6 minutes is up. I'm giving you the murmur. Okay, just hold on. Sorry. I got the wrong murmur here actually. So audible, that is wrong murmur. Okay, so that is different murmur. So the murmur is maximum in the aortic area. Okay.
Okay, sir. So some disturbance is coming, friends, please.
Kindly mute yourself, guys.
Yes, sir. So next, I would like to ask the child to ask Raja to bend forward in a friendly way.
Dr.
Yes, sir.
Amar, Dr.
Yes, sir.
Amar.
Yes, sir. Yes, sir. Yes.
I'm changing the finding, please. So here you are getting the murmur. Okay. Just a minute. See, online, this is the problem actually. So here there was the same murmur which is low in intensity, but on the left side again here is the maximum intensity of the murmur. Okay, and I'm changing the apex. Apex is normal position, that is fifth intercostal space. Okay.
Okay.
Sorry. Actually, I kept this murmur and that somehow changed actually. Okay.
Oh, okay, sir. Okay, sir. So I will ask him to take a deep breath in and out and hold it in the expiration. So is the murmur better heard, sir?
Well, so that is most prominent in the second intercostal in the left side, and there's no change in the yeah, that murmur is changing with respiration, and here is the murmur. Now you can hear the murmur. Okay.
Okay.
I think it's a similar kind of murmur. I think you got the murmur. Okay.
In the back, am I able to see the radiation?
Yes, the radiation is there.
Okay, sir. So I would like to complete my examination by auscultating the basal areas of the lung and look for hepatosplenomegaly and also pedal edema.
So hepatomegaly is not there, spleen is not there, and pedal edema also not there.
Oh, okay, sir.
So you can present your case.
Yes, sir. Today I was able to, today I had the opportunity to examine a lovely 7-year-old boy, Raja, who was cooperative. And on the examination, he had mild pallor and mild pallor and with good dental hygiene. on the auscultation of his heart, I was able to hear an ejection systolic murmur in the left second intercostal space. The murmur was radiating to the back. There is no signs of infective endocarditis, and there is no evidence of any congestive cardiac failure.
What is the most likely diagnosis?
The child has some dysmorphic features of suggestive of Williams syndrome, sir.
Okay, that's great. Then
Murmur and on the auscultation, the signs are auscultative signs are suggestive of pulmonary stenosis.
okay, so what are the other murmur? What are the other DDs of this murmur here?
Other DDs will be atrial septal defect. Can also present with ejection systolic murmur.
Okay, fine. How will differentiate between AS and PS and ASD and PS?
Atrial septal defect murmur will have first a fixed wide splitting of the second heart sound, whereas in the pulmonary stenosis, the second heart sound will be single, and sometimes it will be soft, sir.
Okay. Okay.
And murmur will be radiating with the back in case of pulmonary stenosis, whereas in ASD there is no radiation. And in sometimes in the case of ASD, when the defect is large, there also can diastolic murmur can also be heard in the tricuspid area to increase the flow due to increased flow.
Okay, what are the investigation you want to do?
Yes, sir. First, I would like to check the child's previous records and also do a complete physical examination. And also, I would like to involve my consultant. I would like to check for complete blood picture to rule out any anemia. Next, I would like to do a complete four-limb saturation, SpO2, and also I would like to check the PP. And during the physical examination, I forgot to mention JVP and blood pressure of all the four limbs as well, and also all the peripheral pulses I want to feel. Yes.
Investigation.
So investigations, I want to do 2D echo. Echocardiogram will be diagnostic. Chest X-ray and ECG should also be done.
What is the ECG finding?
ECG in case of pulmonary stenosis, mild pulmonary ECG and chest X-ray can be normal, whereas in the severe defects, there can be evidence of right ventricular hypertrophy, like
Right.
yes, tall V1, tall R waves in V1.
Okay. When surgical intervention will be needed in pulmonary stenosis?
In the pulmonary stenosis, if the gradient across the pulmonary valve is more than 40, then it is surgically indicated, and also if the patient is symptomatic clinically, then also surgical intervention is needed, sir.
Okay. What are the
For,
modalities of treatment?
First would be balloon valvuloplasty can be done if it through the femoral vein.
Okay.
If it does not if the defect is not amenable or if it is not possible, then valve replacement can be done through the central steroid.
Okay. How will manage this child?
This child requires a multidisciplinary team approach. I would like to involve my consultant as well, and cardiologist should be referral should be taken should be involved, sir. And dietitian is important in ensuring, and genetic counseling is also important.
Excellent. Okay. So your time is up. Just maybe it's over a question. These are the typical questions. Sometimes you will get common question, okay, just like that. And in your examination, in that management, have you mentioned the developmental pediatrician?
Oh, okay.
Yeah, that is a big part,
Right.
And another important area, when you are examining the child during your introduction, you need to talk to the child, because this child usually have some developmental low IQ, developmental delay.
Oh.
So you need to find it out, and you need to mention in the management part as well. Like Williams syndrome may come as developmental station as well, like right.
Yes.
So that's why this developmental delay will be there. So IQ, checking of IQ during your introduction.
Mm.
Talk to the child, actually that is called
Mm.
engagement with the child. And you well picked up the physical features, but the facial dysmorphism, it not adequately actually you mentioned. So can anybody suggest what are the other features in this child of Williams syndrome that is present here? Any other suggestions?
Stellate iris.
Stellate iris. And
He has got a happy face, a
yes,
broad nasal nose, and
okay.
stellate iris has already been mentioned, and
Mm.
I think the forehead is also quite broad.
Yeah, sometimes prominent, yes. And the thing is, thick lips will be thicker.
Yes.
And this, nasolabial fold, as Dr. Amar mentioned, that is most likely that will not be there, right? And
The thinning
sometimes,
of the upper lip and the broadening of the lower lip is there.
yes,
is
mostly, and they are very happy. And sometimes posteriorly rotated, like yeah, me or may not be. So these are the finding, and with this finding, you need to pick it up this like diagnosis. Okay. Okay, well done, Dr. Amar. And
I forgot grading of the murmur and
yes, so that's
soft
why I
blowing best
said
heart with
that.
action.
That's why I said I will share this book with you guys. So that is really helpful. And if you have, that's fine. Just go through the presentation part of CVS cases and memorize it. And during your presentation, you will just present the positive finding only. That will help. Okay.
Okay.
Dr. Pranab, I just wanted to ask, before starting the examination, also we need to wash our hands, and also after examining, we need to wash our hands and thank the patient for being cooperative and all that. But it will take a lot of time, no?
Actually, no. This is not time taking. The thing is, when you are entering the room, just at the same time, you will find out some washing of the hand is exactly not needed. There is sanitizer, so use the sanitizer at the same time you introduce yourself. So both the tasks you are doing together.
Yes.
You are rubbing your hand with the sanitizer at the same time you are introducing yourself. And after introducing to the examiner and the child, and take the permission from the mother if the mother is there, and then start the examination with a general examination first. Okay. And do not rush for the examination. So the key in clinical examination, what happens, if you observe the child carefully, lots of information you will get. So in real pressure, under pressure, what happens, if you stay calm during your exam, and ultimately that is going to help. Not like what I will examine, I will forget the steps. Just like if you are puzzled enough, at that time there is chance you will do some mistakes. Just be calm and confident and observe the child, and just think what may be the case. For serious cases, sometimes if the dysmorphism is not there, if not there, then you need to auscultate it and pick up the finding. But before that, you need to follow the structure, because nowadays it's domain marking system is there. Okay. So if you are not giving even the correct diagnosis, then you will get also marks from the other domain. So maintain the structure of examination, and after that try to come to a diagnosis. At least try with logically, not exact diagnosis they are expecting. Okay. But the logical thing you need to say according to your finding, what is there in the child. Got my point?
So is it okay if we do not reach the diagnosis? Sometimes it might be difficult to reach the diagnosis. So is it
Well,
okay?
that depends examiner to examiner. But what I know, I have discussed with several examiner, even the teachers. They, according to their opinion, it is very difficult to give that specific diagnosis. That is not the criteria to get marks. Even if this is difficult, suppose postoperative case, okay, and there may be several murmur, so that is not possible to come to a conclusion. And whatever the finding you are getting, try to describe the murmur. I am getting this systolic or pansystolic or even maybe systolic as well as diastolic murmur in that particular area, and my differential diagnosis, that is possibility, are this. So that will be enough to pass the station. But if someone is just mentioning the irrelevant thing, unlogical thing, then that is the candidate is in danger. So try your best to pick up the murmur and describe whatever you are getting in the station. Yeah, so that is the way actually.
All doubt, sir.
Yeah, please.
Is it ejection systolic only, sir? That murmur? Not sure. I was unsure actually.
Yeah. This was ejection systolic. I'm just playing one more time. Just minute. The same murmur. No, previously I just.
Yes.
So if you hear a few cases maybe in your cardiology unit, if you have the opportunity, please go with the patient and listen several types of murmur if it is there, if you have the facility actually. And
Dr. Pranab,
yeah.
Aortic stenotic murmur.
Sorry.
This is in the right second intercostal space.
No, not right. It's left.
It is left. Okay.
Okay. So that's why. And aortic stenosis murmur as well. That is also ejection systolic murmur, but the site is different, right? Okay. So we have done 3 cases, and I think we'll continue again tomorrow. But you guys just go through the theoretical part and practice yourself a regular basis. So practice is the thing that will ultimately be helpful.